That's it. Okay. So as we all know, the clinical spectrum is a wide range of clinical spectrum, from the neonatal, rapidly fatal, severe disease, to an adult onset with chronic neurodegenerative disease, which, as I heard, in Australia, most of the patients are actually the adult onset. However, in Israel, most patients are actually the neonatal severe fatal disease. And disease severity defined by neurological involvement. So the demographic of NPC1 patients in Israel currently, not including, of course, the deceased patients, we have total of 14 patients. And just to compare, Israel is currently 10 million people only, okay? And we have the 15th one is going under workup as we speak. Only three of them are over 18. All of these are Jewish origin, and the other ones are 6 Muslims and 8 are 6 of our patients are of Muslim origin and 8 are of Jewish origin. 7 were treated by cyclodextrin, whether it was phase 1, 2, or phase 3 study. And there's one who is treated by arimoclomol as part of a French French group. Right. So if you go back to this nice algorithm, which is adapted from Dr. Vanier from France, you can see that there is the spectrum of appearance of the disease manifestations during life. And what is important in our cohort is actually the neonatal cholestasis, which is a lot of time leads us to diagnosis very, very early, sometimes during even their stay in the NICU. And what we also found, and I'll show you, is that a lot of our patients with NPC1 has actually lung involvement, which is not part of their neurologic deterioration. If we look in the Israeli map, in Israel's map, and I'm not going into politics, so just don't look at it this way, please. If we go to the northern part of Israel, then most of our patients there are Muslim Arabs. We have 3 patients. There are 8 patients in the center of Israel, including Jerusalem. And if you can see here, this huge part of land compared to the other parts of Israel, which is the least occupied, has the Bedouins patients, which I'll show you a little bit more, which are, again, Muslim patients that reside all in the southern part. So if we go, this is the biggest Bedouin city in Israel, and it's located in the south, of course, and called Rahat. If you look here, what I wanted to show you is that there are people who are living in normal houses compared to people living in shacks. And here you can see it more properly. You see that there are shacks. There are also, in some areas, even tents. And as you have here, your sign, traffic sign for kangaroo, we have it for camels. And that's the only place, I think, maybe in Saudi Arabia also, but it's only in the south of Israel. You don't see it any other places in Israel. And it's true, it's very, very frightening. I don't know about kangaroo, but this one can kill you when it crosses a car. It's very, very dangerous, and we had cases like that. So here, I'm going to go over a publication we had in 2018. And what you can see here, it's 9 patients out of cohort of 13 patients that we had at the time. And 7 of them, if you see here, had interstitial lung disease as diagnosed. The other 2 was written as wheezing, recurrent wheezing or pneumonia, which probably was also interstitial lung disease, but we didn't know it at the time. So if you think about it, out of cohort of 13 patients to have 7 or 9 patients with interstitial lung disease, that's a lot, which means, and we also got the support after we published it because we had another patient who at the age of 1 month already developed interstitial lung disease, and he died out of his lung disease at 3 months. So that was an additional support for our paper. What is also interesting here, that the presentation of the lung disease was very, very early, as you can see. And additionally, You can see here that the numbers, the 2, 2, 3, and so on, all of these are siblings or related. So this population has a very, very high consanguinity rate. That's why we have recurrent patients from the same tribe. And one of my friends from Israel who is here would support me when I say that a lot of time when these patients are even in the NICU or very, very young in the neonatal period, if they have cholestasis and they have the right name, we go to diagnosis immediately. So we usually have very, very early diagnosis due to that because we diagnose a lot of diseases by names. What we also had, this is one of our patients, one of the patients described in the table. We had a pathology of his, and this is his lungs, which if you look at this pathology, this looks more like a liver consistency, which is very, very bad, assuming that this is a lung. What we can also see here is a lot of foamy cells everywhere in the lungs, in the alveoli. If you look at the lung CT, you can see that he had bilateral infiltrates, which are not supposed to be, okay? And this is from bone marrow, also again, infiltrated by a lot of foamy macrophages. About a year or two later, a colleague of mine from the NIH did a study on a knockout mice with NPC1. And I didn't write here the mutation, but these mice were homozygous to a mutation which led to almost no protein, no NPC1 protein at all. So a very severe phenotype. And what we can see here with the arrows in the red on the left, which these are the homozygous or the knockout mice, you can see that there are a lot of lipid droplets, which were not supposed to be, and also a lot of foamy cells. We can also see that if the normal surfactant, which is very important for lung function, here it looks like an onion layers. Here, nothing looks similar to onion layers because they have mostly foamy macrophages, and that's all. So they thought that maybe part of the explanation for lung disease was that that surfactant, which is built on cholesterol actually, was not built properly, and that's why they had the lung disease, which leads me to our assumption. Our patient's mutation was actually very close by to the NPC2 ligation. So we thought that maybe these patients a little bit presented a little like NPC2. If we go to ages of presentation, you can see in this old slide from, I think, 2003, that most patients actually presented during the first 5 years of life. While, as I said before, in Soroka, which is the hospital where I work, and we cover the whole area of the south of Israel, all patients present within the first year of life, most of them within the first few months of life. Oh, shit, sorry. So this table I actually brought to show you something interesting that we also saw from our patients. This is a paper talking about term versus preterm babies with inborn errors of metabolism in the NICU in China. And if you can look here, you see that full term, most of the patients with different inborn errors of metabolism actually were presented in term babies. Almost none were present in, almost none of them, the premature babies presented with. And I took it to a different place because the few next slides are actually on one of my patients who was diagnosed as in the NICU. She was born 31 weeks gestational age, and she had a persistent cholestasis. And we all know that most of the patients with persistent cholestasis, the cholestasis resolves, and it could be years before they actually present with a disease. And so she had the persistent cholestasis, and due to her last name with the cholestasis, we checked her alpha-feto-protein, which was high, and I'll show you also about that in a few slides. And then we checked her genetics, and we found that she was homozygous to the same mutation that all of our patients actually have. And this is the patient, as you can see, a very, very sweet kid. And what was interesting about her, that after her cholestasis resolved, the parents she was lost to follow up because the parents actually didn't believe us. And then she came to my follow-up when she was 3. And until then, she was like a normal kid. And I'll show you movies because it was hard even for me to believe that this is how she was. And this is when she was, actually, it was 3 years ago. And you can see small baby walking. She's the only patient in our cohort that actually got to walking, talking. It's like unbelievable. If I hadn't seen the movies, I wouldn't have believed the parents. And this is, again, her. She's writing, standing, nothing to write home about, right? And this is her about 1.5 years ago. And you can see here a little bit ataxia, but no more than that. And sometimes if we see it in a regular kid, you say, well, it's the beginning of walking, talking and stuff. Maybe that's part of it. What was really sad about this baby, but this patient, is that her mother and her father are related, of course. Not only that, when I saw the grandmother, which I didn't see at the beginning, I said to her, oh, we know for a long time. Apparently, 3 siblings of the mother died from Niemann-Pick C. So, I mean, and she wasn't able to get into any trial because when we were in the process of, when they approached me, it was way too late. And now she's in vegetative state, which is so very, very sad. Okay, so another paper that was published from Israel a number of years ago showed that sometimes we have prenatal diagnosis of NPC1 due to different signs like hydrops, severe ascites, and so on. And when you have the presentation antenatally, these patients usually are very, very severe and they died within a few months. Most of them died within a few months of birth, as you can see in this table. Another interesting marker that we found, we saw that when we had patients with severe or persistent cholestasis, we usually, part of the diagnosis was actually checking for alpha-feto-protein as part of other diseases. And we saw that every time we had a Niemann-Pick C1, it was accompanied by highly elevated alpha-feto-protein during cholestasis, and it became our marker. We also, that's what you can see here, we also published it here because we saw with a collaboration of another team that it was like 1-to-1. Every time we had a persistent cholestasis, highly elevated alpha-feto-protein, in our patients it was NPC1. So the differential diagnosis could be a lot of things, other lipidoses, idiopathic neonatal hepatitis, and other conditions with ataxia. But we always have to remember the different mechanisms of disease for neuronal loss, because this could be targeted treatments in the future. So we have neuroinflammation, which was found, we have oxidative stress, impaired lysosomal calcium homeostasis, and there were trials even in animals about giving calcium blockers and stuff like that. However, even today, we only have 2 things that are really approved. One of them is, of course, supportive symptomatic treatment, and the miglustat, which is also approved not all over the world, but mostly in Europe. I don't know about Australia, sorry. And in Israel, it is approved, it's even in the basket. So my belief is that only combination therapies would work in the future. One treatment would be enough. And I would concentrate mostly about cyclodextrin because we are part of it, and I'm proud to be part of it. So if we go to miglustat, this is a paper published, I think, 2009 regarding miglustat, and you can see that the most definite side effect is diarrhea. So my patients, none of them would take miglustat because they had such a terrible diarrhea, they just couldn't stand it. So it was like each parent said it in a different time, but none of them would give their, and since they have, most of them have more than one patient, one kid, they already know. So even when the next one is born, they won't give miglustat, they won't even try. Not only that, we know that only around 75–80% of patients actually respond to miglustat. So this is an additional study just published in 2023. We checked the actual cohort, the actual subgroup, which is our group, which is the neonatal infantile, severe infantile type. And you can see here that when they checked loss or acquisition of different milestones, motor milestones, there's no difference whether these patients, and they compared 10 who were on miglustat to 16 who were not treated with miglustat, probably some kind of historic group. But you can see that there's hardly any difference between the two groups, whether you were on miglustat or not on miglustat, which raises the question whether it really helps this group. And not only that, when they did the Kaplan-Meier, you can see here the difference between the untreated, and the treated group. And this, when you do the statistics, is not significant difference. So especially if we talk about side effects, it's not really clear if it's worth even treating with this for this specific subgroup. I do have patients who are on miglustat and enjoy it. Whether it really did help them or not, we don't know. They're stable, and I'll show you. So we were also involved in the phase 1, phase 2 of cyclodextrin trial. And I chose these two graphs because I think they show how much it helps. This is about the tau levels, which are marker for neurodegeneration, and we can see the improvement in each patient, which are actually adult patients, not ours. And here we can also see the marker for cholesterol release, which is also lowering down, meaning that there is an improvement. And I want to add my addition, the way we saw it. And Caroline accompanied me when we saw the first treated patient in Israel. She was a 16-year-old of Ukrainian Jewish origin, a female, that she'd stopped talking about a year, I think over a year even, before we started dosing, and stopped talking completely. Before that, she spoke both Hebrew and Russian, stopped completely. And after, when she finished the first infusion, we were shocked because she started counting in Hebrew suddenly. So of course, it didn't stay with her. It goes down until the next treatment, but still for us, it was, wow, amazing. We also had another patient from Ukraine who was 11 years old, male. And we saw that under treatment, he was much more focused and with us. And unfortunately, because he was in Ukraine, he couldn't get the expansion treatment and he deteriorated. I was in touch with him and he really deteriorated. And I really wanted to show you one of the patients who is still on the treatment. She was in phase 1, phase 2, and you'll see this sweet kid who's now, I think, around 7 years old. Huh? Yeah. You see? Right. Something is wrong. Why doesn't it work? So I'll tell you. Sorry, this was the nicest one. So this lovely girl, she started with the treatment. She started walking. She became toilet trained. She started talking. I mean, she's still, of course, ataxic, but she's amazing. And she understands everything. She's really amazing, amazing girl. And I don't know why it doesn't work here. Worked even in the morning before. Yeah, you saw it. You have to tell. I'm not saying it just myself. So in summary, most Israeli patients have the neonatal early infantile phenotype. Some of the Bedouin patients, or most of the Bedouin patients, have interstitial lung disease. We also know that NPC1 can present antenatally as hydrops, congenital thrombocytopenia, or congenital cholestasis. Increased alpha-feto-protein in newborn with cholestasis should raise suspicion for NPC1 and therefore go to genetics. Premature infants with NPC1 may have a delayed presentation or of a severe phenotype, like I showed you. And also, miglustat is not well tolerated by all patients, as we all know, and may be ineffective in very young children. And with that, I finished. If there are any questions.